eminent Professor Dr. Mohamed Sobh, and the talk about ANCA-associated glomerulonephritis, induction and maintenance immunosuppression.
بسم الله الرحمن الرحيم. طبعا أشكر زمايلي في وحدة أمراض الكلى في مستشفى الجامعة إن هذا المجهود الرائع في مجال النفرولوجي والطفرات اللي بيعملوها كل سنة في المؤتمرات بتاعتهم، وأشكرهم لدعوتي لإلقاء هذه المحاضرة عن ANCA-associated vasculitis. It is very important topic. First, we know that the kidney is a major target for different type of vasculitis. And we know that vasculitis could be classified into large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. And this figure shows clearly the large vessel vasculitis, such as giant cell arteritis, Takayasu arteritis, medium vessel vasculitis, such as bone arteritis nodosa and Kawasaki. And from these two groups, it is bone arteritis nodosa, which can play with the kidney. And the major part of my talk today is small vessel vasculitis, especially the ANCA-associated vasculitis. We know also there is another group of immune complex mediated vasculitis, and vasculitis due to paraneoplastic syndrome, and vasculitis associating many inflammatory bowel disease. But we'll focus on what's called ANCA-associated. We know there are three main types: the microscopic polyangiitis, granulomatous polyangiitis, which was named as Wagner, and eosinophilic granulomatous polyangiitis, which was called Church-Strauss. Regarding small vessel vasculitis, we know it is a necrotizing polyangiitis that affect predominantly small vessel than arteries, including capillary, venule, arteriole. However, arteries may also be affected. The most common renal target, as we know, it is glomerulocapillaries, i.e. glomerulonephritis, especially necrotizing crescentic glomerulonephritis. This is the clinical pathological hallmark of glomerulonephritis, nearly equal, but there are some differences. We know the Wagner, characterized by granulomatous vasculitis, necrotizing vasculitis, involving upper respiratory and kidney. Eosinophilic, beside granulomatous vasculitis, there is eosinophilia, and microscopic polyangiitis characterized by no eosinophilia, no granuloma. So these are the three main types. We know the main characteristic of this lesion are post-immune crescentic glomerulonephritis, but sometimes there is no systemic manifestation, and mainly it is renal, so we call it renal-limited vasculitis. Usually there is generalized manifestation of inflammation, such as fever, malaise, anorexia, weight loss, myalgia, arthralgia. This can be present in any of the three main types of small vessel ANCA-associated vasculitis. But sometimes these syndrome are followed or following upper respiratory infection as a trigger. Also, not upper respiratory infection, sometimes drugs could be the initiating event, such as hydrazine, propylthiouracil, penicillamine, and adulterated cocaine with levamisole. These drugs can initiate vasculitis. So, by definition, patients with microscopic polyangiitis don't have granulomatous respiratory tract. It is mainly Wagner which can cause this. But microscopic meningitis can cause upper respiratory manifestation through angiitis, but without granuloma. Sometimes cardiac disease is identified in approximately 50% of patients with eosinophilic granulomatous meningitis, and in only 20% of patients with vaginal and microscopic meningitis. Actually, last month I saw a case like this. He was a young, nearly 20 years old patient coming with severe vasculitis, with chest pain, and ECG findings suggestive of acute coronary syndrome. And actually, I sent him to cardiologist. Possibly he may need interference, CAS, and these things. But as well, I gave him a potent immune suppression. Due to a reason or other, he didn't know cardiac interference, but the patient improved dramatically by immune suppression. So cardiac manifestation can exist in these patients with systemic vasculitis. Peripheral neuropathy can be a manifestation, especially mononeuritis multiplex, can be presented especially in patients with eosinophilic granulomatous polyangiitis. Also, central nervous system through vasculitis affecting the meninges could be a presentation. Gastrointestinal involvement can be a presentation with bleeding per rectum and hematemesis. And actually, we saw the case presented yesterday in this meeting with hematemesis due to vasculitis affecting the duodenum and stomach. This is the well-known picture of vasculitis, and this is the ANCA with proteinase 3, C ANCA, and myeloperoxidase perinuclear type. But we know we have to do both immunofluorescence assay and ELISA assay to detect the ANCA and to know the type of ANCA. So although positive results are rare in completely healthy individual, approximately 1/4 of patients with other inflammatory renal disease, such as lupus, and can show B-ANCA, for example. And also B-ANCA or ANCA can be detected in other inflammatory, non-renal, extra-renal inflammatory condition, such as rheumatoid and inflammatory bowel disease. It can show ANCA. So ANCA is not specific for small vessel vasculitis. But ANCA testing has good sensitivity, up to 80 to 90% can be positive. But patient with concurrent ANCA and anti-GBM is there and will carry poor or more difficult prognosis. A very important point is the epitope-specific assay may provide much better correlation with and the prediction of this outcome. This epitope-specific assay is very important. So this will explain having patient with positive ANCA and no disease activity, and very active disease and absent ANCA. Possibly there are some epitopes which has no pathologic consequences, and other epitopes with very strong correlation with pathology. So we need further look for epitope-specific for ANCA evaluation. I will not go through this, the pathogenesis of ANCA-associated vasculitis, but this is a case of necrotizing glomerulonephritis with crescent and ANCA-associated vasculitis. And this is angiitis affecting vasa recta, also important. This is circumferential crescent with necrotizing glomerulonephritis. Regardless of the category of ANCA disease, the best clinical predictor of renal outcome is the glomerular GFR at diagnosis. Now, if we go to the treatment, the goal should be not to overtreat mild disease and not to undertreat severe disease. Here is the wisdom. Treatment involves 3 phases: induction of remission, then maintenance of remission, and treatment of relapse if it occurred. Now, we come to the induction. The consensus is that corticosteroid alone are not effective for induction therapy as corticosteroid if we compare it with steroid and other cytotoxic drug. So the rule is to give combined treatment, corticosteroid and cyclophosphamide. This will induce remission in 75% at 3 months and up to 90% at 6 months. So induction means combined treatment, steroid and cyclophosphamide. The regimen, the doses depend on the regimen to which you will follow. For example, this is a regimen of methylprednisolone. We give balance 3 days, then we'll go down to maintenance, high dose, and later on tapering. Cyclophosphamide could be oral or intravenous cyclophosphamide. And of course, we adjust the dose according to the white count. And in elderly, and when there is renal impairment, you have to modify the dose. This slide shows the comparing the initial high dose intravenous versus oral glucocorticoid administration. Meta-analysis concluded that a longer course of glucocorticoid are associated with fewer relapse. So fewer relapse, but more toxicity of this corticosteroid. And here come the wisdom, when to increase the dose, when to taper, and so on. Cyclophosphamide could be given oral or intravenous. There are a lot of trials which shows that the outcome more or less will be equal. But with intravenous cyclophosphamide, use a lower or smaller cumulative dose of cyclophosphamide, consequently less side effect. So possibly intravenous cyclophosphamide is preferable over oral. Now also for induction, we can give rituximab, and here there are 2 good trials using rituximab, and actually the reports give the good result. You can use it for induction. There are 2 trials regarding this point, which conclude that both trials showed that rituximab was non-inferior for induction remission compared with intravenous cyclophosphamide or oral cyclophosphamide. So rituximab is a good option. Plasmapheresis is another strategy to remove pathogenic ANCA, as well as inflammatory mediator from the circulation. Plasmapheresis has been shown to have a therapeutic effect in patients with ANCA disease, including ANCA and anti-GBM disease, who have severe renal impairment with serum creatinine more than 6 milligram, or on dialysis, and those with alveolar hemorrhage. We know this category of patient carry the worst prognosis. So plasmapheresis can help in this critical situation for induction of remission. Regarding maintenance of remission, after we will go down with the momentum of immunosuppression. Once remission has been induced, continued lower level immune suppression is needed for most patients to prevent relapse, which usually entail low-dose glucocorticoid and addition of immunomodulatory drug as azathioprine. Rituximab can be used also, and MMF for long period, up to 1.5 years. Maintenance therapy may be for a short interval or not required for patient at low risk for relapse, such as patient with myeloperoxidase, ANCA, who have complete remission and are not, and they are negative. More prolonged maintenance may be appropriate for patients with increased risk, such as those with C-ANCA, or having history of recurrence, or have pulmonary involvement. So you need to give longer immune suppression. Sustained dose of cyclophosphamide is not recommended because of toxicity, of course. A randomized controlled trial compared cyclophosphamide for 12 months with maintenance therapy with azathioprine. Once complete remission is attained, demonstrated that no difference in outcome. So of course, as maintenance, you use azathioprine. Another option, MMF, and this study, very interesting study against what we believe, azathioprine was better than MMF as a maintenance to maintain remission. Methotrexate is another option, but we as nephrologists, we usually don't use it. The rheumatologists use methotrexate more common than us. Rituximab to maintain remission is a very good option, actually, is another option to maintain remission. The maintenance of remission using rituximab in systemic ANCA-associated vasculitis trial compared rituximab 500 milligram IV every 6 months versus azathioprine for remission maintenance in this patient. Actually, the result was in favor of rituximab. Rituximab was better than azathioprine for preventing relapse, including renal relapse. So this is a good point. If relapse occur, of course, we'll use the same protocol used to induce remission. Observational data suggests that the best treatment for relapse may be rituximab. There is mounting evidence that use of rituximab for relapse is superior for over cyclophosphamide. Reinstitution of treatment similar to an induction regimen is used most often, but less intensive and less toxic therapy may be adequate. In addition to rituximab or cyclophosphamide, a number of therapies can be used in the treatment of relapse, including azathioprine, MMF, methotrexate, or combination of these drugs. In those who have a much smaller risk of relapse, all therapies may be stopped, provided the patient and physician can do well monitoring of course. The risk of relapse is about 10 to 15%, even with remission maintenance therapy. Now, what about the trimethoprim sulfamethoxazole and maintenance of remission? There was some paper which say this. Some studies have suggested a benefit, but others have not because of an increased likelihood of relapse. So we can use ciptrine with other drugs used for induction and maintenance of remission, and don't use it alone. Regarding transplantation, renal transplantation is not a contraindication in patients with end-stage renal disease by ANCA-associated vasculitis. In a multi-center experience, the vasculitis relapse rate was 0.02 per patient per year, very little. A positive ANCA titer at the time of transplantation does not increase the risk of recurrent disease in the transplant. Recurrent ANCA-associated glomerulonephritis in the renal transplant responds similarly to recurrent disease in native kidney. As with native kidney disease, an increased ANCA titer and an active urine sediment should suggest recurrent glomerulonephritis, but the diagnosis requires, of course, kidney biopsy to confirm it. So we may conclude that prompt diagnosis and the rapid initiation of effective treatment are the most important factor for optimum outcome in patients with ANCA-associated vasculitis. Current management strategies are superior to those in the earlier decade because of more effective, more targeted drugs and treatment regimens that are more personalized to the nature of the disease in individual patient. Ongoing advances in understanding ANCA disease mechanisms and development of more effective, less toxic, and more targeted therapies undoubtedly will lead to even better outcome in the future. In addition to rituximab or cyclophosphamide, a number of therapies can be used in the treatment of relapse, including azathioprine, MMF, methotrexate, or combination of these drugs tailored to the individual patient with this active treatment. And thank you.